My name is Shelby Wright, and I'll be presenting my research focused on characterizing genetic referral patterns, uptake, and outcomes for pediatric patients with indications of hearing loss. I have no conflicts of interest to disclose. The learning objectives for this presentation were to identify the demographics of pediatric patients seen at the Children's Hospital of Michigan for an indication of hearing loss, to characterize the referral patterns to genetic services for this patient population, and then to describe the clinical outcomes for those who received genetics evaluations. The purpose of this study was to gain insight into genetic referral practices for those managing patients with hearing loss, and we aim for this information to be used to inform medical management, enhance the diagnosis of genetic forms of hearing loss, and just ultimately improve overall clinical care. So a little background information. Early diagnosis and intervention for hearing loss is essential for optimal outcomes, particularly in areas such as speech and language development, social development, and school performance. And because of this, newborn hearing screening was implemented across the U.S., which unsurprisingly increased the detection of hearing loss in infants. It's important to identify the etiology of hearing loss, though, because this can assist with predicting the progression and prognosis of the condition, as well as potential comorbidities that may be expected to manifest. It is estimated that genetic etiologies account for up to 50% of all congenital hearing loss, with about 1/3 of those being syndromic and presenting with other features. Yet despite this contribution of genetics, there actually seems to be some inconsistency in the clinical recommendations regarding when to offer genetics evaluations. In scouring the literature, we found that there's quite limited data on genetic referral practices for pediatric patients with hearing loss. The most recent study was published in 2019 and specifically looked at patients with mild to severe sensory neural hearing loss. It was a retrospective chart review that looked at the records of just over 300 children from 3 different medical centers across the U.S., and what they found was referrals to genetics were significantly different among all 3 locations without any clear explanation as to why. However, this study is outdated as the data used was collected prior to 2012, and since then, next-generation sequencing has really changed the landscape for genetic testing, with the development of comprehensive testing options like large panels, whole exome, and whole genome sequencing. These have really improved the diagnostic yield for genetic testing for hearing loss, and this study just may not fully capture that. So we decided to conduct a chart review that would reflect more recent practices. Our study aims to characterize referral patterns of pediatricians in a single institution for children with hearing loss to genetic services. We did this through quantifying the frequency of referrals and evaluating the characteristics of patients that received referrals compared to those who did not. We also aim to assess genetic referral uptake and outcomes. So we did this by quantifying the frequency of referral uptake, characterizing patient factors related to referral uptake, and for the patients seen in genetics, describing the outcomes of those evaluations, including whether genetic testing was performed, whether a diagnosis was made based on this testing, and whether any changes or recommendations were made for medical management or any other follow-up. So this was a retrospective chart review that looked at medical records for patients seen at the Children's Hospital of Michigan. Records were collected for patients between the age of 0 and 18 years, and for those who were seen for at least 1 visit over a 10-year span, so from 2014 to 2023. We identified relevant records by filtering ICD-10 codes that were pertaining to hearing loss. Hearing loss types that were admissible in this study included sensory neural, conductive, mixed, and audiological neuropathies, as well as both unilateral and bilateral, and mild, moderate, severe, and profound degrees. Patients were excluded if their hearing loss had a known non-genetic cause or if they were previously diagnosed with a genetic condition that would explain their hearing loss. Data was extracted using a chart search tool and was then recorded and scored in an Excel spreadsheet. And while one member of the research team extracted and scored the data, 10% of the patient's charts were randomly assigned to 2 other members of the research team to be scored as well, as a means of auditing our accuracy of our scoring system. Any discrepancies identified during this process were just resolved through team discussion, and then all the data was re-reviewed for consistency. Data analysis included descriptive statistics describing patient demographics, as well as t-tests and chi-squared tests to assess the differences in characteristics between referred and non-referred groups of patients. So as for our results, we had a total of 75 patients included in the study. The majority of these patients were female, African American, and had Medicaid insurance. Majority of the hearing loss was bilateral sensory neural. We had very similar amounts of mild, moderate, severe, and profound degrees. The age of onset, majority were under 1 year of age, and correspondingly, majority had failed their newborn hearing screens. Comorbidities were present in 39% of the patients, with facial dysmorphism and cardiac anomalies being the 2 most common. So we found 40% of our patients received referrals to genetics. Patients who received referrals had significantly lower ages of onset and more failed newborn hearing screens, as well as a significantly greater number of comorbidities present. Factors that did not significantly differ between referred and non-referred patients were the type, laterality, and degree of hearing loss, as well as insurance coverage, sex, and ethnicity of the patients. So out of our 30 participants that received genetics referrals, 18 or 60% actually followed up and attended their appointment. All 18 were offered genetic testing, and 15 out of 18 completed this testing. Out of the 15, one patient actually received a diagnosis from that testing. This diagnosis was for a condition called Van Maldergem syndrome, and it was identified through whole exome sequencing. This patient had unilateral severe conductive hearing loss, as well as several other comorbidities. For the types of tests, majority of patients had more than 1 test ordered from them, and the 3 most common types of tests were panels, cytogenetic testing, which was primarily chromosomal microarray, as well as whole exome sequencing. So our finding of 40% of our patients receiving referrals to genetics, while research on this topic is extremely limited, this number does appear consistent with the range that we found in the literature, which was about 25 to 40%. It's important to note that there's variability still present, and given that genetic etiologies account for 50% of hearing loss, we might say these referral rates are on the low end. But one possible influencing factor on referrals is the accessibility to genetic services. Studies have speculated that hospitals that have genetic departments in-house or on-site genetics providers may be more inclined to refer patients for workups than those that must refer to external institutions. Additionally, providers with more exposure to genetics professionals may be more comfortable and familiar with the role of genetic testing in the workup for these patients. Children's Hospital of Michigan does have a pediatric genetics department, and they provide education to providers, which may explain in part why their number of genetic referrals fell on the higher end of that range at 40%. It wasn't surprising that the age of onset influenced referrals, as younger age of onset is consistently associated with genetic etiologies of hearing loss. Although another factor that might have played a role in this particular study was our exclusion criteria, removing patients who had already received a genetic diagnosis prior to hearing loss onset. So older children and adolescents with later onset hearing loss may have presented with alternative manifestations earlier in life that warranted a workup and diagnose them with a genetic condition that would then predict their later onset hearing loss, and these patients would have been excluded from our study. As for comorbidities, there are studies that suggest the presence of comorbidities are risk factors for hearing loss, and that parents appear to be more likely to pursue and follow through with genetic evaluations when comorbidities are present. It's also important to consider different perspectives on hearing loss. Members of the deaf community often view deafness as a cultural identity rather than a disability, and many do not see hearing loss as something that needs to be fixed or explained. So as a result, they may not feel that genetic testing is necessary. However, if there are additional comorbidities present, families may feel there's more reason for concern and may be more inclined to pursue further assessments. And when it comes to the type of hearing loss, data is quite limited because most studies restrict their participants to one type of hearing loss. However, we did find in the literature that it was consistent that degree of hearing loss did not significantly impact genetic referrals, though laterality did, with bilateral hearing loss being associated with genetic referrals more often. This doesn't really come as a surprise, as we typically associate bilaterally affected organs with genetic etiologies. However, it is interesting to note that our only diagnosis in this study was made in a patient with unilateral conductive hearing loss. And for our referral uptake rate of 60%, this does seem consistent with what is found in the literature, though rates reported in the literature vary greatly from about 46 to 88%. According to the literature, main reasons we don't see patients attending genetic referrals is due to patients just being lost to follow-up, insurance decline or delays, and families choosing to decline their referral either just due to timing or other obligations, such as a sick child that has other healthcare needs that take precedence. As for our diagnostic rate of 6%, when comparing this to the diagnostic yield of the top 3 testing methods, which ranges from 11 to 40%, this does seem to be on the lower end. One possible reason for our lower diagnostic rate could be that our patient population was primarily African American, which is unlike the other studies we've referenced. The African American population is consistently underrepresented in genomic data, which can lead to higher rates of variants of uncertain significance. This would be consistent with what we found, as our study had a 27% VUS rate. It could also be due to our inclusion of broad types of hearing loss, whereas many of the other studies restricted hearing loss to sensory neural and bilateral types, which do tend to make up the bulk of genetic etiologies. And it may also be an artifact of a small sample size. We only had 15 patients complete testing in our study, in our sample. And another study looking at a similar sample size of about 14 patients who underwent testing reported similar diagnostic yields of just 7%. So of course there are some limitations of the study. We couldn't include referrals or genetic assessments that were made outside of this single institution. We did have a smaller sample size with limited diversity, although our diversity being primarily African American is somewhat of a strength of this study, as it contributes much needed data on this underrepresented demographic. And we also did not account for family history and that impact on referral practices. So it'd be helpful for future research to take a more narrow scope, comparing referral practices between specialists, and to deeply explore barriers to accessing genetic services for this specific demographic of patients. Thank you, and I hope you enjoyed this study or this presentation.
Hello everyone, my name is Teresa Kruselbrink and I'm the Director of Medical Affairs at Helix. I'm excited to share an ongoing project within the Helix Research Network looking at the impact of population-wide genetic screening on the detection and management of familial hypercholesterolemia. I have no disclosures other than I am an employee of Helix. By way of background, familial hypercholesterolemia, or FH, is a genetic disorder characterized by lifelong high serum levels of LDL cholesterol, which, if left untreated, cumulatively contribute to an increased risk of early onset atherosclerosis and cardiovascular events. FH is typically inherited in an autosomal dominant pattern involving pathogenic variants in genes central to lipid metabolism, including LDLR, ApoB, PCSK9. Despite a global prevalence of approximately 1 in 250 individuals, FH is underdiagnosed and undertreated. Because high cholesterol levels and coronary artery disease are common in the general population, in the absence of genetic screening, FH often goes undiagnosed. The Helix Research Network is one of the largest precision clinical research networks that screens an all-comers population of adult patients for CDC Tier 1 genetic conditions, including FH, hereditary breast and ovarian cancer, and Lynch syndrome. Today's discussion is focused on outcomes related to FH. There are currently 15 participating health systems, and 9 of those contributed data to this analysis. Our research analysis leverages data from over 228,000 research-consented patients, with that number growing each year. During our time today, I will be reviewing the following 3 objectives. The first, evaluating the effectiveness of a network of population genetic screening programs in identifying FH patients. Number 2, assessing the frequency of documentation following identification of FH in the screening program. And 3, determining the impact on treatment and management of LDL levels. Starting as early as 2017, participants underwent clinical-grade exome sequencing at Helix for evaluation of pathogenic variants. Individuals with a positive screen were contacted by the study team to disclose the result, and all were offered genetic counseling at no cost. Subsequent care was expected to follow standard clinical protocols within each health system, and EHR data were also collected in a standardized format from all participants for research purposes. FH prevalence was determined. Electronic health records were examined for documentation of the diagnosis, lipid-lowering therapies, and serum LDL levels before and after genetic screening. Additionally, the EHR was examined for evidence of genetic counseling. The study compared treatment adjustments and LDL reductions between patients with documented FH diagnoses and those without. Let's take a look at the results from Objective 1. Is a population screening approach effective in identifying previously undiagnosed FH patients? The answer is yes. Across the 9 health systems, we identified over 1,100 individuals with an FH-associated pathogenic variant, which equates to an overall prevalence of about 1 in 198 individuals. 84% of patients were newly identified through the screening program, and while only 16% had a diagnosis of FH prior to the program, 78% had been diagnosed with general hyperlipidemia. As displayed here, most individuals had a pathogenic variant within LDLR, followed by ApoB. We did find 1 homozygous LDLR, all others were heterozygous, and we also screened for the autosomal recessive form of FH resulting from LDL-RAP1 variants. However, no homozygous individuals were identified with this gene. Let's look at the incidence of pathogenic and likely pathogenic variants relative to the patient's highest reported historical LDL. I have 2 different groupings of LDL along the y-axis. Those in blue represent a comparison of participants with LDL levels either over 250 or under 250, and the bottom part in yellow are showing the comparison of those with LDL levels of either greater than 190 or less than 190. Along the x-axis is the percent of patients with pathogenic or likely pathogenic variants falling into each of these groups. Among the patients with at least 1 LDL result, about 17% of those with an LDL of over 250 have a variant consistent with FH. Compare this to the 0.36% of those with an LDL level of under 250. This corresponds to an odds ratio of about 57, meaning that the odds of a patient with an LDL of over 250 having FH is about 57 times greater than the odds of finding an FH patient in someone who has an LDL level of less than 250. If we use the cutoff of 190, we see that about 3.32% of patients have FH, whereas only 0.27% of those with LDL less than 190 have FH. Now let's move on to our results from Objective 2. Are FH patients identified in the screening programs documented appropriately? Yes, some are, but there is much room for improvement. In the graph along the right, we show the percent of FH positive patients that had their new diagnosis documented. On the top in the lighter blue shows that 46% of the positive FH patients had their diagnosis documented. Unfortunately, that means that 54% shown on the bottom in the dark blue had no evidence of a new FH diagnosis, and this was after a median total follow-up duration of 21.1 months, indicating that there is definitely room for additional interventions. Finally, let's review the outcomes from our third objective in determining the impact of a new FH diagnosis on treatment and LDL management. Here we show baseline patient characteristics for patients with and without FH among the subset of patients with at least 6 months of retrospective and 6 months of prospective EHR data available. Similar to our broader network, the mean age of FH patients was 51 years, with 74% being female, and this is not dissimilar from those without an FH variant. Compared to participants without FH, those with FH had higher mean concentrations of LDL cholesterol based on both the most recent pre-screening measurement and the highest available historical measurement. Patients with FH were also more likely to have been previously treated with an LDL-lowering agent, with 57% having ever used one previously and 38% in the prior year. We can also see a fair amount of treatment in the patients without FH variants. And here we see that patients with an FH variant are also more likely to have a prior diagnosis for coronary artery disease, 17.2% versus 7.4%. Importantly, although 78% of FH patients had a diagnosis for general hyperlipidemia, only 16% had a prior diagnosis for FH documented in the EHR. We were interested to understand if there was an association between documentation status and LDL treatment status, and there was. The graph on the right shows positive patients and whether they had a diagnosis of FH prior to screening along the y-axis. And the percent that had an LDL-lowering agent in use in the prior year is on the x-axis. You can see that patients with a prior clinical FH diagnostic code documented were more likely than those without a prior diagnosis to have used an LDL-lowering agent within the year before screening, and this is 62% versus 33%. In the next green graph, we look at positive patients who were previously untreated. Among positive patients with no LDL-lowering agent use in the prior year, those with a new clinical FH diagnosis documented in the EHR were more likely than those without the diagnostic code to be newly prescribed an LDL-lowering agent during the same period, and this is 58% versus 15%. And in the yellow bars at the bottom, among patients who did have LDL-lowering agent use in the prior year, those with the new diagnosis documented were more likely than those without the diagnosis documented to have some form of therapeutic change. This slide shows the breakdown of new and modified LDL-lowering therapy prescriptions post-screening in patients with FH. Shown in the top half of the slide, among previously untreated patients, almost 31% received a new treatment within the first year after screening, with statins being the most common. Among previously treated patients, along the bottom, 37% had at least one therapeutic change within the first year after screening, with comparable proportions among the different modifications shown. The next question is, are these therapies making any difference in LDL levels in FH patients? In this slide, we have plotted the distribution of the largest LDL reduction achieved on the y-axis and show the difference between those who did not start lipid-lowering therapy in the first year, shown in pink, and those that did, in green. Over a median of 16 months of available LDL follow-up, patients who started treatment, again in green, had a maximum mean reduction of 57 milligrams per deciliter, or a percent reduction of 33%, which was significantly higher than the 17 milligrams per deciliter mean reduction seen among patients with no treatment initiated in pink. This slide shows similar data now among patients who were previously treated in the prior year and stratified by whether they subsequently had a therapeutic change in the next year. And we see that patients with a therapeutic modification post-screening experience larger maximum LDL reductions with a mean reduction of 48 milligrams per deciliter, or 32%, compared to 22 milligrams per deciliter in those without modified treatment. However, even when only looking among individuals with a high baseline LDL of greater than 160 and evaluating LDL reductions as a percent change, we still see significantly larger LDL reductions among patients with therapeutic additions or modifications compared to those without, shown in pink. Another way to look at this is to evaluate whether the LDL target goals are achieved, which are defined as achieving either a greater than 50% reduction in LDL or achieving an LDL of less than 70 milligrams per deciliter. Patients with the new or modified therapy were more likely than those without therapeutic additions or changes to achieve these targets. 39% of those with new or modified therapy achieved one of those two targets after a median of 8 months, whereas only 15% did among those with no new or modified therapy. And finally, since this is a genetic counseling focused conference, I wanted to provide some data on the association of genetic counseling with the clinical outcomes. I'll caveat this by saying that we were not able to get robust genetic counseling data from all of our health systems. We have a separate genetic counseling uptake study that is looking at that. However, we were able to see provider specialty data for GC visits for 3 of our health systems. So in this graph, you can see the percent of FH positive patients at each of those health systems who had a genetic counseling visit within 1 year after HRN enrollment, or within the minimum of 6 months available for follow-up. Among the 216 FH positive patients at these health systems, 52.8% had a genetic counseling visit within 1 year compared to only 2.7% in the general population. Among those 216 FH positive patients, 48% of the patients with a GC visit received new or modified LDL lowering therapy prescriptions within that same 1-year period, compared to only 17.6% among patients without a GC visit. Among the subset of FH positive patients with available baseline and follow-up LDL results, the mean max LDL reduction was about 49 milligrams per deciliter among patients with a genetic counseling visit, compared to 23 milligrams per deciliter among patients without a GC visit. In summary, within a large population genomics program, we found that 84% of patients with an FH-associated pathogenic variant lacked a prior clinical diagnosis and were newly identified through screening. EHR documentation of the FH diagnosis code was associated with a 2-fold greater likelihood of patients receiving new or modified lipid-lowering therapies. Similarly, we saw a positive association of receiving new or modified therapy in patients who had genetic counseling. While these associations are not necessarily causal, it suggests that formal recognition of FH within the medical record may reflect or facilitate more proactive lipid management, including the initiation or intensification of therapy, and that having a genetic counseling appointment may also help to facilitate appropriate documentation and downstream referral. Positive screening results should be effectively integrated into clinical workflows to drive appropriate therapeutic action. Not surprisingly, new or modified treatment was associated with large LDL reductions, with 39% of patients who started or changed therapy having achieved a 50% reduction or an LDL level of less than 70. Based on the literature, the mean reduction observed in that group would be estimated to equate to about a 30% cardiovascular disease risk reduction, which is substantial. These comparisons affirm the likely positive impact of treatment changes on LDL management following receipt of a positive genomic screening result. We encourage continued monitoring and additional analysis of cardiovascular outcomes to evaluate the longer-term benefits of population screening. I would like to thank all study participants, the investigators at each of the health systems participating in the Helix Research Network, as well as my colleagues at Helix for making this work possible. More information about our study can be found in our recent preprint posted on medRxiv through the QR code below. Thank you.
Hello, my name is Bethany Zettler, and I'm excited to present about our experience recruiting for the BabySeq2 project using some community-informed strategies. My co-authors listed on this slide include members of the research team, as well as members of the BabySeq Community Advisory Board. I have no conflicts of interest. So you may be familiar with the idea of newborn genome sequencing as a potential supplement to standard newborn screening. Using broad genetic testing may help identify additional health risks early in life. However, some previous studies, including the BabySeq1 project, have been limited by non-diverse enrollment and mostly included participants from white backgrounds and with high socioeconomic status. And if we're going to study implementation on a population scale for public health, it's really important to include more broad representation in research. So BabySeq2 is a randomized controlled trial of newborn genome sequencing in well baby care. And one of our main goals of this project was to reduce barriers to participation and promote enrollment, especially among diverse populations. So to support this goal, our first step was to establish the BabySeq Community Advisory Board, or CAB. So we invited parents and other community members representing our enrollment sites to join this group and partner with the study team. We met about quarterly by Zoom and provided an annual stipend. We also identified recruitment clinics at our enrollment sites, typically serving pretty diverse populations. Our initial 5 sites are included on this slide, and that is the data that you will see today. Recruitment began in January 2023 and proceeded for about 2 years. BabySeq Clinical Research Coordinators, or CRCs, were embedded in these recruitment clinics and approached families of infants throughout the first year of life. For families who chose to enroll, we administered a survey to the parent or guardian, which included some questions about demographic information and some attitudes towards genomic medicine and motivations to enroll. And for declining families, we asked their main reason for decline and categorized those responses by themes. We also obtained demographic information from the medical record, which does have its limitations. Finally, after the enrollment period, we distributed a feedback survey to our CRCs. For this analysis, we compared rates of enrollment and decline across demographic groups and looked at reasons for decline by demographic group. We also studied our enrollment rates over time and specifically in relation to protocol amendments informed by the CAB. And finally, we used parent and CRC survey data for some further insights. So in total, our CRCs approached over 2,300 families. We had 663 participants enroll and 671 decline. The remainder were undecided. The majority of our enrolled cohort identified either as Black or African American or Hispanic or Latino, which again was one of our main recruitment goals, was to reach these participants. And overall, about 85% identified as non-white. Looking at some other socio-demographic information, about half of parents reported their annual household income as less than $40,000, and about 40% reported their education level as high school or less. To collect information about race and ethnicity, we had parents select any number of options that aligned with their infant's background, and we studied uptake based on this self-reported background and found that those identifying as Hispanic or Latino only, or as multiracial or multi-ethnic, were significantly more likely to enroll than other groups. We examined this finding further by recoding our parent-reported data based on Hispanic ethnicity, and we found that participants with any Hispanic or Latino heritage were significantly more likely to enroll than non-Hispanic populations. It was about a 45% uptake rate compared with about 30%. And looking at parent language, there was also higher enrollment among Spanish-speaking populations, but this did not reach statistical significance, likely due to a smaller sample size. As a sneak peek, we do have a poster looking at retention, and we found that Spanish-speaking participants are significantly more likely to stay enrolled, so it does seem like there is a pattern there as well. And based on our CRC feedback surveys and the literature, we think that this uptake is related to hiring CRCs from concordant cultural backgrounds and language skills, especially for clinics serving a large Hispanic and/or Spanish-speaking population. We also had all of our study materials professionally translated and reviewed by Spanish-speaking team members, and this type of strategy has been shown to be effective in other studies, so we're glad to see that replicated here in the newborn sequencing research context. And of our 671 families who declined participation, 539 provided at least one reason for that decision, and the percentages here indicate the frequency of those reasons. The most common reason for decline, about 40% of responses, was because I do not want my child or family to participate in research. So that was just a general opposition to any research, not specific to this study. About 25% declined because this specific project didn't sound interesting or beneficial. And then we had some reasons common to other clinical trials, such as a lack of time or hesitation around a sample collection. You'll notice that reasons related to genetic testing or data sharing or potential insurance discrimination were much less commonly reported. Reasons for decline were mostly consistent across demographic groups, with a few important exceptions. And these graphs show those trends, omitting groups with very small sample sizes of less than 3. So the top half of the slide shows that families from Black or African American backgrounds were significantly more likely to decline because of opposition to any research participation. And unfortunately, we know that historic abuses by researchers and ongoing biases within the medical community have fostered well-documented mistrust among African American populations. And in BabySeq-2, we did have some success with enrollment. However, this shows that there's still a lot of intentional work to be done in reaching these potential participants. And the bottom half of the slide shows that families with Asian infants were most likely to decline participation, specifically due to concerns around genetic testing for their children. This was also a relatively small group, and the literature emphasizes that Asian Americans are quite heterogeneous with a very wide range of attitudes towards genetic testing. However, this trend did make us reflect that we had not included any perspectives from the Asian American community on our CAB, so this is definitely something that we can do better in future iterations and continue to explore. And looking at how enrollment changed over time, when we started in January 2023, we were at less than 1 consent per week, which was not going to be effective for our recruitment goals. So we submitted 3 important protocol amendments, each informed by CAB input. And looking back, enrollment rates did increase after each amendment, all the way up to almost 10 participants per week, closer to August. So each of these increases was statistically significant, and the largest increase in enrollment was related to participant compensation. So we did not change the overall amount. It was always $150 per family total, distributed at 3 time points tied to the parent survey completion. But we did change the compensation structure from escalating to consistent. So we had started out with an escalating structure, which the literature suggests is helpful for retention because the longer someone stays in the study, the higher compensation amount they receive. However, we heard from our CAB and our CRCs that initial lower payment amount of $25 was just not sufficient for the amount of time we were asking for, including the consent and the parent survey and a potential sample collection. So instead we changed it to a consistent $50 per time point, and we used gift cards available at a very wide range of stores, and we distributed those immediately upon survey completion. And so these compensation changes and methods were followed by a large increase in consents per week. And our CRCs endorsed this strategy as effective on our feedback surveys. So looking at some attitudes and potential motivations among our enrolled participants, we had 574 families complete the baseline survey. And that survey included the genomic orientation scale, which consists of 26 questions rating the likely effects of genomic medicine over the next 5 years. So there are 2 subscales, and our participants had an average optimism score of 5.61, indicating they were quite optimistic, and this graph shows they were more optimistic than the validation sample or reference population for this scale. And then the average pessimism score was negative 0.55, meaning they were not pessimistic, which again is a better outlook than the reference sample where people did predict some negative outcomes of genomic medicine. So overall, this pattern indicates a true optimism or an idealistic attitude towards genomic medicine. We also looked at some qualitative data on parent motivations. So the survey includes an optional free response question, just is there anything else you would like to tell us about your feelings towards the BabySeq project? So 41 families provided an optional response. Of these, 80% of them were coded as positive, the remainder being neutral, and common themes included just general positive feelings towards the project, being excited to learn results, and feeling optimistic that this could improve future health. Our CRCs also endorse that parents do seem motivated, excited, and interested in this project. So in conclusion, our efforts with community engagement did result in the enrollment of a diverse cohort. We identified 2 specific strategies that led to meaningful changes. The first was hiring CRCs from concordant cultural backgrounds, which was especially effective with our Hispanic and Latino participants and Spanish-speaking participants. This strategy has been well described in the literature, and again, we're glad to see it replicated here. Secondly was using this consistent compensation structure that is respectful of the time involved. That really made a difference in our consents per week, and I think this shows that it's important to plan for, respectful compensation from the beginning, ask the community what a reasonable compensation level is, and make sure you have funding for it and a plan to distribute that effectively. Our main reason for decline was a disinterest in any research rather than opposition to newborn sequencing. So I do think this is encouraging for larger scale efforts that are ongoing, when we ask parents if they want to participate in something like this, there's not a ton of specific pushback against genetic testing. However, we did find that work is still needed, especially among specific populations. We found that Black or African American populations were the most likely to be opposed to any research participation. And we found that of our enrolled participants, they had positive attitudes towards the study and overall felt pretty optimistic about genomic medicine. So we are also hopeful that similar strategies could help with representation in other genomic research studies and eventual equitable implementation of this technology. So I have a massive team to thank and acknowledge. This work would not be possible without everyone on this slide, as well as our funders and of course the entire BBC Community Advisory Board. So thank you all, and I appreciate the opportunity to share and for you taking the time to view this presentation. Thanks.